Today's art interview, sponsored by Grows on Main, located at 136 South Main Street in Butler, Pennsylvania. The shop has an inventory of common and rare plants, some you'll not find anywhere else, community-wide. As soon as you walk in, you know you're in a special place. They also have an event space, which holds events like baby showers, bridal showers, birthday parties, and much more. So come on down to Grows on Main, look at some of the wonderful plants they have, and maybe book your event.
This is art. Any recovery topic is art. Joining me today is Douglas, and Douglas is a therapist or a counselor. How would you label yourself exactly?
Therapist is fine.
Therapist? Okay. Now you're in the mental health field, correct?
Yeah, and substance abuse.
Okay.
Yeah.
Interesting. So this podcast basically is about recovery. It's recovery based, and I work in the field myself, and we see quite a few co-occurring people come through.
Sure.
Mental health always seems to be at the base of it, most of the times. However, every now and then we get clients that will come through specifically as mental health, but it turns out they actually have substance use as well. Do you find that in your field as well?
Absolutely. Yeah, I definitely agree that they both play on each other, and they're both, substances are used to alleviate and medicate the mental health symptoms. And a lot of times mental health issues can hide substance use that they don't see as negative or consequential until they look at it closer. So I firmly believe, and that's why I have a co-occurring specialty, when I went to school to get that, understanding, and I firmly believe they're both related strongly. Yeah.
How long have you been in the field?
8 years, 8.5 years professionally. Looking back on it, I kind of think that I've been in this field most of my life, just because both my parents were in the social work field, and I kind of learned from them that being attuned and helping other people is very important, and understanding that everybody has a life and a story to tell. And so I've through all of my career endeavors, I've always used a helping and understanding, communicating with people approach. And so I think, I've probably been practicing therapy longer than I've been actually a professional therapist. So
now, in your practice, what is your primary therapeutic model that you use?
I treat everybody through a trauma-informed lens. I don't use one specific model just because I think there's, people aren't one specific problem. And so I try to blend a lot of, ACT, mindfulness, EMDR, person-centered. I kind of start with person-centered just to build a rapport and really, engage the therapeutic relationship. And from there, I kind of, where the client's needs are, that's where it takes me as to what model I try to implement. So very flexible.
The ACT, this is something that I've talked with, I interviewed Billy W. He's also a therapist at a rehabilitation center. And I know that they're big on the ACT program.
Okay.
What is it? Accountability and commitment therapy.
Acceptance and commitment.
Acceptance.
Yeah.
Correct.
Sure.
Yeah. I thought I was wrong, but I was wrong. I knew I was wrong.
I've been wrong many times. It does take a few seconds to roll off the mouth a little bit, and I'm by no means am I an expert at it, but I believe in it, and I've the 6 dimensions are just a big part of just who I am therapeutically and what I like to bring to a client's, treatment and care, because it's very appropriate.
What kind of population do you find yourself working with usually? Is it mostly adults, or is it a mixture of adults and adolescents?
Primarily adults.
Primarily
I have
adults.
had some adolescent clientele, but I've always, mainly stayed within the adult population.
Other than co-occurring disorders, what other kind of disorders do you see outside of substance use? Do you see things in that? Do you work with things in the realm of like schizophrenia and different areas like that?
Moderately, just through the community health setting that I work in. We do have clients with schizophrenia, significant, schizoaffective disorders, and so their presentation can get significant.
What's the difference between schizophrenia and schizoaffective?
My impression has always been schizophrenia is more defined personalities, different personalities, and schizoaffective tends to be, I'm trying to think of the words, it's induced by more stress and external factors. I think schizophrenia is just more organic, where there's defined personalities. Schizoaffective has to do with, trauma and other mental health conditions, and stress can bring out the schizoaffective personality symptoms. So they still can present as a separate or different kind of identity, but it's just they're slightly different.
Okay. Do you think that trauma accounts for most disorders?
There's a relationship there.
Oh, definitely.
Yeah. I always try to educate the clients in that, trauma is different than what a lot of people think trauma is. Obviously, abuse, conflict and war, death, and those kind of natural disasters are traumatic. But on a lot of different levels, a young child being at home with two working parents can have a traumatic relationship with the young child because his needs aren't getting met. And so I think it's important to really reframe what the experiences are for the person, and to let them identify, how, because a trauma necessarily is kind of a separation from oneself. What's core? When a human being doesn't get their needs met, that can be perceived as a traumatic experience.
I heard Gabor Mata
Sure.
talking about that, and he was speaking about himself actually and his own mother, and how there were needs that weren't met. I wish I could remember the name of the video, but it was pretty enlightening.
Mm-hmm.
I think that trauma plays its role in substance abuse more times than not, it seems to me.
Absolutely.
Yeah.
Yeah.
Can you treat substance abuse first, or would you want to treat the trauma first? Or do you need to treat both at the same time? Do you have an opinion on that?
I personally would look more towards the trauma, because the trauma is underlying the emotional states, and the trauma has a subconscious element to it, and how our bodies respond to the environment, and most times that leads to substance use, or leads to consequential behaviors, because the person can't really maintain an internal comfort, safety, calming presentation, and so they seek some kind of relief, some form of distraction externally. So absolutely, I firmly believe that, and somebody told me once, drugs and alcohol are just a coping mechanism gone bad. So drugs and alcohol are not evil, they're not bad, they're not the problem. It's just they're choosing something that has very, very strong and significant consequences to deal with an internal emotional situation.
Yeah, that's interesting because when I found drugs and alcohol, I used it as a coping mechanism, as many people do. And they worked for a while until they didn't work anymore.
Mm-hmm.
You know, when I had entered into recovery, I found that I definitely had to work on both at the same time. And I wasn't going to be able to tackle the issues of my trauma while still using drugs and alcohol. And it kind of goes hand in hand. And I think that that's what I've been able to recognize in 12-step programs, is that they're doing just that. They're using abstinence along with a lot of basic mental health repair.
Absolutely.
Are you familiar with any 12-step program?
Oh, sure. Yeah. I found my recovery, in a 12-step program. So I believe that I like to say just about everybody would benefit from a 12-step program, whether you're substance abuse or not, because it really it's a guidelines to living a better life.
Yeah.
There's the honesty, the spirituality, the constant kind of awareness and the accountability, which is the making amends and other things, and then and taking all this once we've gone through this, then to kind of hopefully gain a sense of wanting to share and give back to other people. Who wouldn't benefit from that, right? It's a great process.
I've always thought that. I have always thought that everyone on the planet could benefit in some way from a 12-step program because of the things that it can provide,
Absolutely.
A way to, and I really believe that all of your great spiritual leaders like Buddha, Jesus Christ, all of these great spiritual people have all pointed to the inside, as meditative, as finding God, finding your way to God on the inside, raising your awareness, raising your consciousness, and looking inside. And really, that's what the 12-step program has done for me.
Sure.
I had never been into therapy per se myself, as far as one-on-one counselor or anything, but I think it definitely would have benefited at one point in my life, naturally getting into drugs and alcohol at a young age. As I mentioned before, I did use it as a coping skill until it didn't work anymore. But by the time it didn't work anymore, I was so knee deep in it that I couldn't pull myself out of it,
Right.
When it comes to meds and prescriptions, does your field look at MATs differently than, say, a psychiatrist? From working in a social environment like the care center or in private practice, because you don't prescribe medications yourself naturally, right?
I do not, correct.
So what would be your stance on MATs, medically assisted treatment?
I support it completely. I believe it's life-sustaining medicine that should be treated with the same, intensity as, any other life-sustaining medicine. And educating the client on the purpose and connecting them to themselves is, I think, that where it separates from a lot of the stigma of, it's still people that are getting high and they're still using and this and that. Well, the people are living functional, lives to their, to their goals, so in their quality of life as well. So who's to say that that's not helpful for them?
Right.
I think Definitely the psychiatric field. There is some bias there. I'm blessed that at the care center there's not, because they do work in the arena of co-occurring, and they see where the drugs and alcohol and the substance use and the mental health meet, and so they're very open-minded when it comes to addressing those needs. So, and we're happy to bring that to the clients, that we can offer them a less, stigmatized approach. But it's a, I think, probably in the 12-step programs, that's been somewhat of an issue, accepting it in certain areas and not accepting it, and whether it's abstinence based. I personally never used MAT, so I support people's choices, and then after that I have to educate them the best I can.
I was actually against medical marijuana when I first entered into recovery. Now, keep in mind, for me, marijuana was one of the hard things for me to step away from. It was something that had been with me all of my addiction.
Okay.
And so stepping away from it and seeing people around me saying, oh, I'm getting my medical card because I need it for my anxiety. And I felt like I had a problem with that, and I would try to be sly and say, well, what's the dosage?
Right.
And, oh, it's as needed. It's like, okay, so can you use it as needed, or do you need it every time you're not high? And recently I had run across, listening to a client, a situation where I was listening to this man explain. Now, he is a veteran,
Mm-hmm.
and I don't want to give too many details away about him personally, but he has trauma from war, and he explained to me that he has his medical card and that he doesn't plan on quitting. Naturally, this is where I entered my, what's your dosage and this and that and everything, and thought I was being slick and everything. And because there's a part of me still, I guess, I just want to help everybody by helping everybody get totally off of.
Okay.
Right.
Sure.
And I believe that it comes from a source of care, and I just want to help. But having this conversation with him actually changed my mind. He explained to me that he doesn't use it before 6 p.m. He will stop using it an hour before he goes to bed. And outside of that, he doesn't use it. And I thought, wow, this man has had a problem with alcohol, but yet he can use this responsibly.
Mm-hmm.
And I have no reason to doubt that he's not telling me the truth. And I came home and I thought about that for a while. For the whole evening, I pondered on that and thought about that. And it made sense, he has one leg, he has trauma.
Mm-hmm.
And I mean, if it was any other medicine, a pill that was prescribed by a psychiatrist, if it was M&Ms prescribed by the cashier,
Right.
and he was using it in the manner that he explained to me that he was using it, I guess I didn't really see the difference anymore in marijuana versus, say, Prozac or something of the nature.
Sure.
So it really did change my opinion.
Mm-hmm.
I believe that it can be used like a proper medicine, as long as the addictive behavior doesn't manipulate the situation to where you're getting high with it and you're acting addictively with it.
Right.
Because I know when I eat M&Ms, I'm very, very much an addict.
Sure. Oh yeah.
But I
addictions
still
are-
let myself,
Yeah.
especially at the movies.
Sure. Well, addictions are not, strictly a substance. There's behaviors that we become, we struggle with addicted to. And of course, people in recovery, once that, abstinence period starts or the MAT starts, then there's substitutions.
Mhm.
So we're going to find that other thing that gives us relief because, we don't have access to the one thing that we've been using for 5, 10, 20 years. And so we're naturally going to want to find something else. And that's why my role is to educate people on, okay, you're seeking something different. What's the consequences? What's the quality of life? What are your choices? Emotionally, what's going on underneath it? Not looking at the substance, because there's many substances that do that. Emotionally, if you can become comfortable emotionally dealing with your environment, then who am I to, judge somebody's, choices for? Because I've worked with many people who were hardcore heroin addicts for, 15, 20 years. And they were clean, they were using MAT, and then they eventually, I might drink a couple of beers or not. And they said they admitted that at a meeting, and all hell broke loose. And they were like, I've had 2 beers in a year. Well, you're not abstinent. Well, my drug of choice was heroin, and they said, it's the same thing as, if you want to use medical marijuana, occasionally to treat if they can socially drink, then that's not a problem for them.
Right.
And I understand completely the mechanisms in the brain of, one substance filling in for another. And my job to educate them. I might judge them for that, but say, are you aware of this? You know how this works? And once they understand it, then they make choices.
Yeah, that reminds me when I've heard it said that the alcohol was just a symptom of the problem,
Oh, absolutely.
And I think that sums it up in a nutshell
Mm-hmm.
and describes it in, great detail right there. I definitely believe that I had a thinking problem before I got into drugs and alcohol. And even after I got sober, well, as soon as I became abstinence, before I got too far into my recovery, I still had a thinking problem, I did go see a therapist once, and she said, I believe you have a hard time showing emotions, and I can't say that I'm surprised. A little therapy joke there.
Yes.
So I've heard that only 7% of communication is accredited to being verbal communication. So what would you look for in a session with a client outside of verbal cues and verbal communications that can help you hone in on getting to know issues with a client better?
Eye contact. The position of the body, I think it has a lot, because if you're a little more open, a little more comfortable, you're going to kind of have a more open engagement. If somebody's not feeling well, if somebody has, if they're new and there's not trust established or their thing, then they're going to be slightly, closed off in one way or the other. They're not going to have quite that holding of the eyes or the face. So that's very, something to just be aware of, and, just in the nature of, I guess it's verbal, but, the outside of the words themselves, but just, how the words come out, that has a little bit of a, secondary little indicator there. Just, body posture, are they attentive to me? Are they attentive to the room? Then I just try to, meet them where they're at, and if I feel like there's they're more interested in what's in the room than me, then I'll start with something in the room, build rapport over that, and then eventually kind of, step into something else.
When you run across clients that, I don't want to say that you can't quite get a read on in the beginning, but I'm sure there are roadblocks a lot of the times, especially in the beginning. So,
Yes.
and naturally there would be like cultural roadblocks, certain communication roadblocks, or even stigma. What kind of roadblocks have you encountered that you found very difficult, but you were still able to overcome? Or maybe even some that were roadblocks that you are still trying to figure out?
It's a good question. I guess I'll start with the roadblocks that I haven't been able to maybe overcome or still are very present for me. Is I do think when you mentioned the psychosis and the more psychotic presentations, I think that's just I still find it interesting and I'll try, but that's where I can probably improve, my game a little bit, maybe, is to do more research or have more practice in dealing with that situation. I feel like I'm very good at, making a situation kind of comfortable, but then after that, I think it kind of slows down a little bit. There's been times where I've had people kind of, maybe pigeonhole me based on whether it's culture or this, and I've had a lot of people discount me and say, I'm not going to work with you. I don't, I need, only a person in recovery would understand what I'm going through. And I'll say, oh, well, let me go ask the guy who's got 12 years. And I'll kind of turn my head and I'll say, so what can I do for you? And like, what, you're in recovery? I'm like, you don't talk like somebody in recovery. It's like, well, I mean, what does somebody in recovery talk like?
And what do they look like?
Right. So, I mean, it's just, and there's been, there's gender and culture. I'm open to it. I try to, I don't come out right and say that, if there's a race or gender difference, I'm going to say, but, I try to make it very comfortable and acknowledge that there might be a gap or a difference, and that I'm willing, to accept that I'm, maybe not what they want or think of, but one of my kind of tenets is always, okay, that's true. That's how you feel. Now, what are we going to do about it? Yeah, I don't like to sit in the, oh gosh, we can't do. I was like, well, no, this is the truth, the reality. You may see me as somebody who's different, who can't or can help you. What can we, it's either we move forward or we find another path. But either way, let's try to, action of some kind, maybe.
I wanted to ask you your thoughts on police and how society reacts to episodes of somebody in a mental health crisis. We see it on the news, we hear stories, we see the results, and sometimes it doesn't end well. A lot of times it doesn't end well. Do you have any opinions on what could change for the better to help the public service in this field, in this area of showing up on a situation where there's a crisis happening because of somebody in mental health need?
The go-to is education, obviously, some form of education and training for anybody. I mean, if the police are here to serve and protect, then, they have all the weapons and all the other gear to help. Well, let's educate and let's weaponize the mind a little bit, and let's get them, maybe better trained and prepared to deal with, a mental health situation. And that's not saying every police officer needs to do that, but bringing something in, like if it's a substance use or a mental health crisis, then, have access to a mental health, crisis person who could at least guide them in some way. So I mean, that's I personally, one of the therapeutic interventions I use is thought-filled therapy, which is the acupressure, the tapping, and it's very quick and it's very effective.
So if you're in a crisis, I would tap you?
No, it's based on acupuncture.
Okay.
So it uses the same
Acupressure then.
acupuncture points, but you use just tap on it. So the if you look at acupuncture, the body, the face, the hands, they have points that when activated in a sequence, they can relieve and activate the release of chemicals, and they can release stress and other things.
Oh, interesting.
So and it's a very thought-filled therapy. It's been a very researched and evidence-based for over 30 years. And it's nonverbal, and so I've used it many times to when somebody's very, very escalated and activated, to kind of calm them down. Get de-stress take that energy out of the body, because it's kind of an energy focus.
Now, if I wanted to look that up, say on YouTube or something, what would I search for? How would I look? What would I look for to find more information on techniques to be able to use for myself?
Thought field, like FIELD therapy is the name of the therapy. On our phones, there's an app called Tapping Solutions.
Oh yeah.
And that was developed by, I think, Nick Ortner. So if you put in Nick Ortner on Google search, he'll come up, and then it's a very popular app. I shared that with a lot of people, and that's a lot of just anxiety, depression, having trouble sleeping. It's more developed towards daily functioning as opposed to treating trauma. But it uses the same kind of mechanisms, uses the same body tapping mechanisms to help reduce the distress levels in the body. But the acute thought-filled therapy, I worked with a gentleman who he had been in federal prison for 30 years, his whole life basically. And so he had learned just to institutionalized, and that was what he knew. And he came to our treatment center, and he was highly activated. He was actually more highly activated because he was out of his element. He was used to be in prison, so now that he was in a treatment center, he couldn't relate. So all of his internal mechanisms, he was separated from who he thought he was. And because being in prison, he knew that violence and aggression was how he dealt with it. Mm-hmm. And so, luckily I had enough rapport with him just to kind of say, hey, let's try something real quick. And I did what we called a trauma quick tapping exercise, which takes about 30, 40 seconds. And he tried that, and he was able to reduce his distress greatly in the minute. So that would have value. Somebody in the street, if you're working with somebody, hey, let's just try this. And then all of a sudden you may have a person struggling be much calmer. So you don't stop somebody who's getting ready to attack you and say, hey, let's tap on our butt. It can be very effective in a lot of situations. And there's a lot of training, probably modalities that you could learn those skills economically. Police department can use those skills. The man I worked with, he was one of the trauma response, crisis response team for Pittsburgh. He was their director for many, many years. And so when the first responders and the police had a crisis moment and they needed to debrief and relieve the stress that they had just gone through, they called his team, and they'd go in and they would do tapping sequences and help them move on from that distress.
Interesting.
So it's a very, very powerful tool. And of course with trauma, it helps to relieve. Doesn't make them forget. It doesn't make the trauma go away. It takes that energy, that response, and reduces it greatly. So where then you can sit and maybe talk about it, or it's nonverbal to start, but then it opens up ways to deal with it. So it's a good bridge to use in a lot of ways.
Yeah, I'm definitely going to look into that. Maybe if I'm lucky, I can find some sort of seductive tapping that after dinner might be beneficial at home too. Uh, well, do you have anything that you'd like to promote that would benefit the local community or people in need?
Everybody has a life, and everybody can, hopefully feel better. So reach out to somebody. Therapy doesn't hurt.
No, it doesn't.
And so, and a lot of good can come from it. They just, know you're not alone. We're out here for you. So
that's key, connection.
Oh, absolutely. The opposite of addiction is connection. And I've seen the Gabor Mate video I think you're referring to, and it's very powerful. I've taken a lot of knowledge and intuition from him and a few of his. And the man that worked with me with the trauma, he uses Gabor Mate as a strong inspiration, because that is a very big part of that process.
Yeah, connection is one of my favorite words now.
Mm-hmm.
Yeah, I'm a firm believer in connection is the purpose for life. Mm-hmm.
Absolutely.
Well, I want to thank everybody for watching. Check us out on YouTube at youtube.com. Any Recovery Topic is Art. Join us on Facebook, facebook.com. Any Recovery Topic is Art. And if you'd like to participate, give us a message, leave a comment. Thanks for watching.